Hi, this is Dr. Poole, and I'm going to talk about the pathology of cerebrovascular diseases in this presentation. Specifically, I'll discuss cerebral infarction and diffuse hypoxic encephalopathy. This is a little bit longer presentation than my usual presentations, but I hope to pick off an important topic with this presentation. Stroke is the clinical designation that applies to all these conditions, particularly when symptoms begin acutely. Stroke is caused by a reduction or interruption of blood flow or decreased oxygen delivery within one or more arterial systems of the brain. Most of the time, this is due to embolic or atherothrombotic occlusion of extracranial or intracranial blood vessels. Focal neurologic symptoms can be dramatic, often with an acute onset. From the standpoint of pathology and pathophysiology, it is useful to distinguish cerebrovascular disease as two processes, ischemic versus hemorrhagic etiologies. Hypoxia, ischemia, and infarction result from impairment of blood supply and oxygenation to CNS tissue. In the brain, embolism is a more common etiology than thrombosis. This process can either be a global process or focal, with the clinical manifestations determined by the region of the brain affected. Hemorrhage results from rupture of CNS vessels and deprives the supplied brain of oxygen through that mechanism. Common etiologies include hypertension and vascular anomalies such as aneurysms and malformations. These will be discussed in separate chalk talks. Many features of the history and physical examination suggest certain stroke subtypes. This presumptive clinical diagnosis requires confirmation by brain and vascular imaging. The most important historical item for differentiating stroke subtypes is the pace and course of the symptoms and signs and their clearing. Each of the subtypes has a characteristic course. This table from up to date outlines the characteristics of different stroke subtypes, and I'll refer back to this in the next couple of chalk talks. But for right now, let's compare and contrast certain key points. Intracerebral hemorrhage does not improve during the early period. It progresses gradually during minutes or a few hours. Embolic strokes, on the other hand, most often occur suddenly. The deficits indicate focal loss of brain function that is usually maximal at its onset. Rapid recovery also favors embolism. Thrombosis-related symptoms often fluctuate, varying between normal and abnormal or progressing in a stepwise or stuttering fashion with some periods of improvement. Penetrating artery occlusions usually cause symptoms that develop during a short period of time, hours, or at most a few days, compared with large artery-related brain ischemia, which evolves over a longer period of time. Finally, aneurysmal, spontaneous, or subarachnoid hemorrhage develops in an instant. Focal brain dysfunction is less common. The two stroke subtypes that I'll focus on in this presentation are ischemic stroke subtypes, which are indicated by the arrows. Recall that the brain is a highly aerobic tissue in which oxygen rather than metabolic substrate is the rate-limiting step for function. It is primarily dependent on oxidative metabolism for the generation of ATP and has minimal capacity to use glycolysis or energy substrates other than glucose. With ischemia and depletion of ATP, there's a loss of the membrane potential that is key for neuronal electrical activity. The brain may be deprived by oxygen by several mechanisms. Hypoxia, caused by a low partial pressure of oxygen, impairment of the blood's oxygen carrying capacity, or inhibition of oxygen use in the tissue. Or ischemia, which can either be transient or permanent, caused by interruption of normal circulatory flow. Cessation of blood flow can also result from a reduction in perfusion pressure, such as hypotension, small or large vessel obstruction, or both. Although reduced blood flow always causes decreased tissue oxygenation, that is, tissue hypoxia, global hypoxia and focal ischemia are distinct pathophysiological processes. A practical classification of the pathophysiologic types of cerebral hypoxia is as follows. Stagnant hypoxia includes conditions in which there is no flow, that is stagnant or ischemic hypoxia, or significantly reduced flow, that is oligemic hypoxia. The wonderfully poetic hypoxic hypoxia refers to the reduced blood oxygen content that may result from pulmonary disease or other conditions that lead to reduced oxygen carrying capacity of the blood, like anemic hypoxia. Cyanide poisoning, which prevents cells from using oxygen to produce ATP, is an example of histotoxic hypoxia. Finally, hypoglycemic hypoxia refers to a reduced ability of the brain to use oxygen in conditions of low blood glucose, which you've already learned about by your study of diabetes mellitus. When blood flow to a portion of the brain is reduced, the survival of the tissue at risk depends on the presence of collateral circulation, the duration of ischemia, and the magnitude and rapidity of the reduction of flow. These factors determine, in turn, the precise anatomic size and size of the lesion and, consequently, the clinical manifestations of stroke. This should sound eerily familiar to you because it's very similar to the location and extent that determines myocardial infarct. This diagram reviews the major cerebrovascular territories and is critical for you to know for correlating neurologic signs and symptoms, imaging studies, the likely vessel occluded, and the anatomic location of an infarct. All right, let's talk a little bit about collateral flow. The major source of collateral flow is the circle of Willis, supplemented by the external carotid ophthalmic pathway. Partial and inconstant reinforcement is available over the surface of the brain for the distal branches of the anterior, middle, and posterior cerebral arteries through cortical leptomeningeal anastomoses. In contrast, there is little, if any, collateral flow for the deep penetrating vessels supplying structures such as the thalamus, basal ganglia, and deep white matter. The main causes of cerebral infarction are atherosclerosis of large vessels or embolic occlusion of distal vessels, or frequently both. The most common causes are atheromatous disease in large and medium-sized extracranial and or intracranial arteries, small vessel disease called lacunar infarcts, which I'll talk about in hypertensive cerebrovascular disease, and embolism from atrial fibrillation or other high-risk cardioembolic conditions. Most infarcts are believed to result from disruption and embolization of platelet thrombi or friable plaque material with subsequent obstruction of intracranial arteries. Uncommon causes include the following: border zone infarcts due to arterial hypotension or poor cerebral perfusion, cervicocephalic arterial dissection, other non-atherosclerotic vasculopathies such as Moya-Moya syndrome or fibromuscular dysplasia, vasculitis such as infectious, necrotizing, those associated with collagen vascular disease or other systemic diseases, giant cell arteritis, also known as temporal arteritis, hypersensitivity vasculitides, and primary CNS vasculitis. And finally, hypercoagulable states such as pregnancy, antiphospholipid antibody syndrome, sickle cell disease, and cancer. Thrombotic occlusions are most commonly associated with atherosclerosis and plaque rupture. The most common sites are the carotid bifurcation, the origin of the middle cerebral artery, and either end of the basilar artery. Thrombi cause progressive narrowing of the lumen, which may be accompanied by anterograde extension, and may progress to fragmentation and distal embolization. Nothing new here. This is stuff that you've learned with myocardial infarction of the heart. We're just applying it to the brain. Embolism to the brain occurs from a variety of sources. Cardiac mural thrombi are among the most common culprits. You should recall that myocardial infarct, valvular disease, and atrial fibrillation are important predisposing factors to the development of cardiac mural thrombi. Next in importance are thromboemboli arising in arteries, most often originating over atheromatous plaques within the carotid arteries. Other sources of emboli include paradoxical emboli, particularly in children with cardiac anomalies, and emboli of other material, such as tumor, fat, or air. Shower embolization, as in fat embolism, may occur after fractures. Affected individuals manifest generalized cerebral dysfunction with disturbances of higher cortical function and consciousness, often without localizing signs. Widespread hemorrhagic lesions involving the white matter are characteristic of shower embolization of bone marrow after trauma. The territory of distribution of the middle cerebral artery, the direct extension of the internal carotid artery, is the most frequently affected by embolic infarction. The incidence is about equal in the two hemispheres. Emboli tend to lodge where blood vessels branch or in areas of pre-existing luminal stenosis, such as from atherosclerosis. This table lists some of the risk factors with stroke. Risk is increased in patients over age 60. Hypertension is the single most modifiable risk factor for ischemic stroke. For each 10 millimeter rise in mercury of systolic blood pressure or 5 millimeter increase in diastolic blood pressure, the relative risk of stroke increases by a factor of 2.3. Little factoid for you. Atrial fibrillation is an important preventable cause of stroke. The relative risk of stroke in patients with non-valvular atrial fibrillation is at least 5 times greater than in patients with normal sinus rhythm. The incidence is higher in men than in women. There's no distinct genetic etiology, but family history is an identifiable risk factor. Perhaps this is related to an familial tendency to increased platelet activation or adherence. Mitral stenosis and left atrial enlargement contribute to the risk of embolic stroke. MI and stroke coexist in 2 to 6% of patients. Diabetes mellitus is an independent risk factor for stroke, increasing the relative risk by a factor of 2. In addition, diabetes is associated with accelerated atherosclerosis, endothelial dysfunction, and a prothrombotic state. None of these are good. Elevated total cholesterol and LDL cholesterol and low plasma levels of HDL cholesterol are major modifiable risk factors for atherothrombotic vascular disease. Smokers have a 4 to 6-fold increased risk of stroke compared to patients who have never smoked. Illicit drug use such as cocaine, heroin, and amphetamines are also risk factors for a variety of things, not just for stroke. Hemorrhagic disorders, primary or secondary hypercoagulable states obviously increase the risk for stroke. Oral contraceptive use is associated with a small but significant increase of stroke. Women who smoke and take oral contraceptives are at even greater risk for thrombosis. Estrogen-containing oral contraceptives should not be used in women with a history of clinical vascular disease, including stroke. Finally, migraines, particularly those associated with aura, are associated with a 2-fold increased risk of ischemic stroke. Global cerebral ischemia, or diffuse ischemic hypoxic encephalopathy, occurs when there is a generalized reduction of cerebral perfusion, as in cardiac arrest, shock, and/or severe hypotension. The clinical outcome of a severe hypotensive episode that produces global cerebral ischemia varies with the severity of the insult. It may be mild and transient with no irreversible injury. With severe global cerebral ischemia, widespread neuronal death occurs, irrespective of regional vulnerability. Patients who survive this injury often remain in a persistent vegetative state. Other patients meet the clinical criteria for brain death, including evidence of irreversible diffuse cortical injury. There is a hierarchy of sensitivity among CNS cells to hypoxia. Neurons are the most sensitive, although glial cells, including astrocytes and oligodendrocytes, are also vulnerable. The most sensitive neurons in the brain are the pyramidal cell layer of the hippocampus, especially area CA1, also referred to as Sommer's sector, cerebellar Purkinje cells, and pyramidal neurons in the cerebral cortex in layers 3, 5, and 6. Border zone or watershed infarcts occur in the regions of the brain or spinal cord that lie at the most distal reaches of the arterial blood supply, the border zones between arterial territories. So this is similar concept to the border zone infarcts that we talked about in the large colon. In the cerebral hemispheres, the border zone between the anterior and the middle cerebral artery distributions are at greatest risk. Damage to this region produces a sickle-shaped band of necrosis over the cerebral convexity, over a few centimeters lateral to the interhemispheric fissure. Border zone infarcts are usually seen after hypotensive episodes. After an ischemic event, the brain undergoes a sequential series of changes. Grossly, the initial stage is diffuse brain swelling with widened gyri and narrowed sulci. Watershed infarction in end artery regions of the vascular supply. Initially, there's necrosis of the most vulnerable regions, which we just talked about. And finally, you can see laminar necrosis of the cerebral cortex, also in these most vulnerable regions. The next couple of images are just for review and comparison. This is a normal brain from the superior aspect. This is a coronal section through the center of the brain, and some important landmarks are described in the text. This is an image of diffuse hypoxia ischemia, or diffuse hypoxic encephalopathy. The brain has a diffuse, dusky, and congested appearance, and this was from a patient who died of cardiopulmonary arrest. In an infarct, these changes would be localized to a particular lobe or segment. In the acute stage of diffuse hypoxemia ischemia, there is diffuse cerebral swelling with gyral widening and sulcal narrowing, resulting from cytotoxic effects of oxygen deprivation on neurons, which lose the ability to regulate ions, accumulate water, and swell, known as cytotoxic edema. The border zones or end artery regions of supply between the anterior, middle, and posterior cerebral arteries, and those of the vertebrobasilar regions of supply in the brainstem and cerebellum are preferentially affected. The patchy areas of softening and discoloration that occur in such border zones are referred to as watershed infarcts. The smaller picture in the inset is normal brain that's provided just for comparison. So you can see the expansion of the white area and the thinned gray matter. Acute hippocampal necrosis can be seen as an early sign of global hypoxia ischemia. Remember, this is one of those zones that are particularly vulnerable to hypoxia. This image shows bilateral foci of watershed infarcts located in the zones between the anterior and middle cerebral artery regions of supply. Now we'll look at some focal infarcts. This is a massive cerebral infarct in an area of anterior middle cerebral artery distributions showing a mass effect and midline shift. Just to test yourself, what type of herniation would you expect to see with this pathology? As this process evolves, in this example of a subacute infarct, the frontal lobe shows liquefactive necrosis with beginning formation of cystic spaces as resolution begins to occur 10 days to 2 weeks after the initial ischemic event. The initial subacute changes begin 24 hours after the initial ischemic injury, with influx of macrophages to remove the necrotic tissue, followed by progressively increasing vascular proliferation and reactive gliosis. I'll go over this in a little bit more detail when we talk about the microscopic pathology. The brain does not have a capacity to restore itself, similar to the heart. So what you're left with is once the process has resolved, resolution of liquefactive necrosis leads to formation of a cystic space, which is surrounded by remaining scarred or gliotic brain tissue. This is another example of a cavitary lesion in the posterior cerebral artery distribution in the occipital lobe, again indicative of a remote cerebral infarct. Similar to the gross, the microscopic features of a reversible ischemic injury or infarction also evolve over time. If a patient dies within 12 hours of severe hypoxia, no apparent changes are observed by routine light microscopy. The alterations associated with acute hypoxemia ischemia are typically observed 12 to 24 hours after significant hypoxia, and at low magnification consists of pallor and vacuolation of the neuropil. High magnification study will reveal neuronal shrinkage with cytoplasmic hypereosinophilia and nuclear pycnosis, remember known as red neurons. This neuronal reaction has been referred to as ischemic cell change, acute neuronal cell change, eosinophilic cell change, or simply red dead neurons. The latter indicates that irreversible damage has occurred. Eosinophilic neurons may persist for several days after an acute event. Early changes occurring 12 to 24 hours after the insult are seen in neurons as red neurons and consist of microvacuolation, then eosinophilia of neuronal cytoplasm. After the acute injury, the reaction to tissue damage begins with infiltration by neutrophils. This should sound familiar again. This shows cerebellar Purkinje cells undergoing red neuronal change with this acute ischemia. This is an image of pyramidal neurons of the hippocampal summer sector, also showing cytoplasmic eosinophilia with nuclear hyperchromasia and pycnosis, again known as red neurons, consistent with acute ischemic cell change. This image shows an influx of neutrophils after 24 hours. These are the cells with clusters of small purple dots. You can see them surrounding this blood vessel and extending into the neuropile. Subacute changes occurring at 24 hours to 2 weeks include tissue necrosis, influx of macrophages, vascular proliferation, and reactive gliosis. Repair becomes robust after approximately 2 weeks and is characterized by removal of necrotic tissue, loss of normal CNS architecture, and gliosis. In the cerebral neocortex, the neuronal loss and gliosis are uneven, with preservation of some layers and destruction of others, producing a pattern of injury that's been called pseudolamellar necrosis. This is the subacute phase of infarct. On the right are many macrophages that are present in the subacute infarct to phagocytize lipid debris from ongoing liquefactive necrosis. Gliosis illustrated by gemistocytic astrocytes, is beginning to appear on the left. This is just another image showing the same thing. Gemistocytic astrocytes indicative of gliosis, and numerous macrophages that are ingesting the necrotic debris. Another image showing numerous foamy macrophages. At the edge of this process are reactive astrocytes indicated by the arrows and oligodendrocytes, which are circled. All right, let's summarize what we've learned about the strokes. Not these strokes, but cerebrovascular strokes. We learned about the definition of cerebral infarction, where they're located, some of the gender and risk factors. You should be able to recognize and describe some of the gross features that are seen in diffuse cerebral hypoxia. We talked about some of the things that modify the location and extent of a stroke, and thus the clinical features. You should be also able to recognize and describe the gross features of cerebral infarction and the temporal sequence of changes that occur, and also the microscopic features that evolve. Note again that the microscopic features are the same for diffuse cerebral hypoxia, and cerebral infarct. So you only have to learn it once. So hopefully this has stretched your brain a bit, but hasn't been too much torture. I know it was a little bit overly long presentation, but I wanted to cover everything in one presentation. So we'll move on to the next two presentations, in this case hypertensive cerebrovascular disease, and then finally intracranial hemorrhage. Signing off.